he has had 11 surgeries on his left knee. At about 60 to 70% improvement on a conservative measure. Obviously, that is a range, so some patients are doing better, and we've resolved people's pains with 1 or 2 treatments. All right, everybody, Fridays at RP. This is how I do it. I'd like to introduce to you, Fridays at RP, we have the lovely naturopathic doctor and outstanding wife and the runner of the show. In all reality, Dr. Myers. She'll likely be making some appearances today. She's trying to get out of the frame. Sometimes actually a lot of the time she tells me not to talk so loud, but that's just the way it is. So let's get it going today. And then we make the coffee. We have 2 staff members out today, one on vacation, one is a spot that we're actually trying to fill. And so because of that, we have to, as owners, have to step up and do a lot of the things that, you know, we've, over the past year and a half, have been able to delegate out, but things like helping with running lab tests, billing, all that type of stuff. Morning, guys. So, another crazy day. So we are getting our PRP processing and room set up for the day. After this procedure here, I'm going to recap what we did in the procedure, and so that way you guys are in the know on that. But we drew 180 cc's of blood, and then we have it sitting here that we are then going to transfer into the sterile conical tubes and do our first spin. Our first spin, the goal of the first spin is to separate out the plasma from the hematocrits, basically separate out the plasma from the red blood cells. In doing so, that allows us to concentrate that plasma into PRP and also PPP, platelet poor plasma. So that way we don't have any red blood cells and very, very, very little white blood cells. So there's going to be a leukocyte poor PRP preparation. Here, this is after our final spin. So if you can see on the bottom here, we have what we call the platelet pellet, and then we have the plasma all up above. And so we're going to take the plasma off, reconstitute this pellet in a small volume of plasma, and that will make our final PRP and then subsequent Good. Draw that up. We look at how much we have. And so see, we only have about 15. So we are going to we make that our 17. Mix it up because we are going to take our last sample. And there we have our final PRP, and PPP. So our approach today. So we're going to do bilateral knees, okay, on the right side. Oh, well, so first we're going to do the lumbar erector spinae plane block. So that's going to be injection. It's basically interfascial plane block. So between the transverse process and the lumbar spine, the erector spinae group, we'll put an anesthetic there. That will help provide some analgesia to the legs to make the procedure more tolerable. So we'll do that. That takes probably about 25-30 minutes to set in, okay. And then that'll continue, and that'll probably last 4 to 6 hours today. Okay. And so we'll get you on the table. We'll do that part first, and then we'll let that kind of sink in. You'll be face down for that. Then you can hang out there. We'll let it wait and sink in. And then the first thing we'll do, because we're already in that position, is we're going to treat that posterior lateral corner, okay, on the left side, and we'll do our intraosseous injection first. Okay, so we'll numb that up with 4% lidocaine, then we'll do that injection, and then we'll flip you, and then we'll do everything else. So on the right knee, we are going to do inside the joint and the fat pad. Okay. Right, the fat pad helps with healing for the meniscus tear that you have, and so we're going to use that to help with the healing. And then we're going to do a saphenous nerve hydrodissection and an infrapatellar branch of saphenous nerve hydrodissection with the pore plasma. Okay. From there, then we'll do the left side. On that, we're going to do inside the joint. We're going to do the fat pad from the scarring that you have. What's likely happened too is anytime we have scar tissue in the fat pad, it usually sticks to the patellar tendon, especially if there's patellar tendinosis. So I'm actually going to hydrodissect the fascial plane in between the patellar tendon, okay, and the fat pad to get a little better sliding surface there. We'll obviously treat that patellar ligament for the patellar tendon for the tendinosis that's there. We'll do the nerve hydrodissection for saphenous and then for patellar branch on that side as well. And then the medial patellofemoral ligament. So that's for the lateralization that you're having on that kneecap. Okay. Okay. So on average, after usually about 2 to 3 treatments, a lot of the patients that we heavily screen and make sure that they are an actual candidate for these procedures, I can't stress that enough, is we're looking at about 60 to 70% improvement on a conservative measure. Obviously, that is a range, so some patients are doing better and we've resolved people's pains with 1 or 2 treatments, and others are a little bit harder to heal, and we might only have 30 to 40% after 1 to 2 PRP treatments. And then just like any medical procedure, we have a failure rate, and so not everybody, even though we do our due diligence to make sure that we are ensuring that they're a candidate first and foremost, there's still some patients who we don't see the response that we hope for.
That's for your...
And that's all we need the PRP for?
Yeah, exactly. That's your patellar ligament. That's the loss of it.
Thank you. So on the Infisa fight, you can use this as well. It's a game changer. It allows us to actually see what we are trying to treat. So that way, when I say to a patient, we're going to treat inside your knee joint and actually inject PRP into the knee joint, I can confirm that with imaging as opposed to just injecting without imaging and hoping that I'm in the knee joint. So it's a huge game changer. All right, so we just finished our PRP procedure for the bilateral knees. This patient has a long-standing history of left and right knee pain. On the right side, he has not had any surgeries, thankfully, but does have a prior meniscus tear. And on the left side, he has unfortunately gone through 11 surgeries, and he is still in pain. So the therapies that we did today is he's having some bone marrow edema in the lateral tibial plateau, the posterior medial aspect, and so we did an intraosseous injection of PRP into that actual bone marrow lesion in order to try and stimulate some healing there. He also is suffering from patellar tendinosis on that side, along with infrapatellar branch of saphenous and saphenous mononeuropathy due to surgical scars and just long-standing repeated trauma to the area. And so we hydrodissected out the saphenous nerve and the infrapatellar branch of saphenous. We also treated the patellar tendon, or the patellar ligament as it probably should be called. And he also had what are called enthesophytes, so basically bone growth at the enthesis of the proximal patellar ligament. And so we treated that as well. Overall, patient did super well for the procedure, and super excited to see how he heals over the next 3 to 6 months. All right, we just finished up another Friday at RP. So recap, we had our PRP procedure for bilateral knee pain with our intraosseous injection for bone marrow edema on the lateral aspect of the tibial plateau, which I believe is going to help this patient a lot with his chronic knee pain that he's been struggling with for so long. Second patient was a PRP procedure for the bilateral feet. This patient has basically some overuse injuries of the plantar plate. So basically underneath the ball of the foot on the actual metatarsal heads, some degeneration in that plantar plate, which causes pain with running. Now, the patient doesn't have pain day to day in terms of just walking around and things like that. Where it really starts to come out is with longer runs. So at about a mile and a half, he'll start to develop pain on the balls of his foot from running from this degeneration. So we treated that with PRP, and then the surrounding nerves with platelet plasma. And then our last case of the day was just a quick perineural treatment with 5% dextrose, where we actually suspect that there's a little bit of metatarsal capsulitis along with some neurogenic inflammation of the interdigital nerves, kind of similar to Morton's neuroma, but a little bit more distal on the ball of the foot. So the last two procedures are actually pretty similar, one with PRP, one with D5W. And that, everybody, is our Fridays at RP. We didn't have a lot of chance to film today in terms of this one-on-one, but we got a lot of footage on everything else. So I'm going to try to grab Dr. Myers to give so she can give you her insight on the day, because it's always very different than mine. But stay tuned if she does. If not, I will see y'all later.